Everyone doing this morning? Good. I see some smiling faces. Well, welcome to our first annual Hot Topics in Lung Cancer. It's a pleasure to have you all with us. My name is Caitlin Wagner, and I work at Wellness House here. I'm a staff member. For those of you who have been coming to Wellness House programs in the past, thank you and welcome back. For those of you who are new to Wellness House programs, we're so glad that you are here. Wellness House is a nonprofit organization that's been around for almost 30 years, providing psychosocial programs, events, and services to those who are affected by cancer at no cost. So if you're interested in learning about maybe our exercise classes or nutrition classes, support groups, counseling, education classes, really anything about Wellness House, I encourage you to find me or another staff member today, and we'd be happy to talk to you and get you hooked up with some of our programming. So I will now start with introducing the event today. So really excited, this being our first Hot Topics in Lung Cancer. Before we get started, though, with the presentations, you do have some items on your seat. So if you could just make sure that you fill out the evaluation, which is in the packets, that yellow page. At the end, before you leave, that helps us determine what changes we could make in the future, or if we did a good job today. And then also there's the agenda for the day to let you know what's going on. There's some other educational resources, the PowerPoints for some of the presentations, and the doctor's bios as well. So encourage you to look at that. We'll start here with the panel presentations. They'll go till 10:30, and then I encourage you all to ask questions from 10:30 to 11. So please hold those questions until that time. There's a notes page, so if you want to jot down your questions throughout the presentations, that might be helpful. And then we will take a break from 11 to 11:15 and come back for our final presentation from 11:15 until 12:30. All right? So I also want to thank Illinois Cancer Specialists, Northwest Community Hospital, the University of Chicago Medicine, Rush University Medical Center, and Amita Health for lending their time, expertise, and resources to us all today. And now I would like to introduce our panel presenters. So this morning we'll begin with Dr. Malhotra from Illinois Cancer Specialists and Northwest Community Hospital. Dr. Malhotra is a native of Chicago. He completed his internal medicine residency and fellowship in medical oncology and hematology at Northwestern Memorial Hospital, McGaw Medical Center of Northwestern University Medical School. He serves as the cancer liaison physician for Northwest Community Hospital Cancer Program. He also serves on national committees of the U.S. Oncology Network regarding pharmacy and therapeutics and value-based care. He has a special interest in the management of various solid tumor malignancies in addition to hematological disease. He enjoys spending time with his family, golfing, and playing pickleball. Our next presenter will be Dr. Mark Ferguson from the University of Chicago Medicine. Dr. Ferguson specializes in the surgical management of disease of the lung and esophagus. He is program director of the University of Chicago Cardiothoracic Fellowship Program. He serves on the boards and committees of numerous national societies and institutions, including the Food and Drug Administration, the National Institutes of Health, and ctsnet.org. Dr. Ferguson is the author of more than 100 chapters in medical textbooks. He has edited or written 8 books, including Esophageal Reconstructive Surgery, Failed Anti-Reflux Therapy, an Atlas of General Thoracic Surgery, and an Atlas of Minimally Invasive Thoracic Surgery. He completed 3 editions of Difficult Decisions in Thoracic Surgery. He is the editor of Difficult Decisions in Surgery, a series of books highlighting decision-making in a variety of surgical subspecialties. Dr. Ferguson has also written more than 300 papers in medical journals. He has served as a deputy editor. He is on the editorial board of 3 other journals. He is the editor of ctsnet.org. and he also serves as the executive director of the International Society of Diseases of the Esophagus. His educational background includes an undergraduate degree from Harvard College and an MD degree from the University of Chicago. His surgical training and fellowship in medical education took place at the University of Chicago. His research interests include risk analysis, long-term outcomes after lung resection and esophageal resection, development of simulation methods for surgical training, and advanced techniques in surgical education. Next, we'll have Dr. Mawaha from Rush University Medical Center. He is a radiation oncologist and received his medical doctorate from the University of Cincinnati College of Medicine in Cincinnati, Ohio. He completed his residency in radiation oncology at the Cleveland Clinic, where he served as chief resident. Dr. Mawaha is an oncologist at Rush University and specializes in treating chest tumors, esophageal cancer, lung cancer, medicinal tumors, mesothelioma, and lymphoma with radiation therapy. I said it correctly earlier. His main clinical and research interests are in the use of stereotactic body radiotherapy, SBRT, for the treatment of lung tumors and metastasis. He is also the director of residency training program at Rush. So with that, I'd like to welcome all of our doctors today, and we will begin with Dr. Malhotra with updates in immunotherapy.
Thank you so much. Oh. Sorry? You can take that off. Thanks. Do you want to go to presentation?
That was my phone.
Great. I wanted to welcome everybody to come out on a Saturday morning with a little bit of snow here. Looks like we're going to have an early winter, so I wanted to really give an overview of immunotherapy and lung cancer. If you watch TV, you know that immunotherapy has obviously become something that's advertised now on primetime TV. I never thought in my career that cancer medicines would be on TV being advertised directly to patients. So just wanted to kind of go through an overview to try to hopefully give you guys some idea of what immunotherapy is and kind of what the directions of immunotherapy will be. I wanted to keep this fairly informal, but wanted to really try to give everybody an idea of why there's so much hype and excitement about this sort of therapy for lung cancer. These are statistics, again, that are well known with over 200,000 patients diagnosed with lung cancer. Of that, 15 to 20% will be typically at an early stage, which can be treated with surgery and or radiation, as our other speakers will talk to. The majority of things that I deal with, in addition to local therapy, are patients who have had tumor who has spread outside of the lungs, and we typically will use other approaches to treat the cancer in that situation. Typically, those will include chemotherapy and radiation therapies, which were really the only treatments that were available for the treatment of lung cancers. But recent advances in treatments really include targeted therapy and immunotherapy. So what is immuno-oncology? Immuno-oncology truly is a field of cancer research that's really trying to understand how the immune system interacts with cancers. Immunotherapy is also, research is also being looked at to find ways of using your body's immune system to treat the cancer. Immunotherapy really is a way that we can stimulate our immune system to help us do what it should be doing. So what is the immune system? The immune system, we hear about it all the time. We hear about people with decreased immune system, but what is its main purpose? Its main purpose is this: it's a defense against disease. It typically includes a network of blood cells, tissues, and organs which communicate and work with each other. They tend to prevent and limit infections by recognizing and really destroying foreign substances. We think about bacteria and viruses, but also trying to help us regulate abnormal cells such as cancer cells. The main crux of your immune system are white blood cells, which are lymphocytes that include certain types of lymphocytes, including T cells and B cells, and these basically play key roles in attacking and killing your abnormal cells. T cells are basically the core of what's called adaptive immunity. Most of immunotherapy that's being focused on now is really focused on activating T cells to fight cancer. B cells are also used. They are cells that produce antibodies, and they attack specific invaders or in unhealthy cells. Antibodies are basically small proteins that produced by the immune system to respond to abnormal things such as abnormal antigens and attack foreign or unhealthy cells. And the antigens are basically little proteins that are on cells that our immune system uses to really trigger an immune response. So the crux of immunotherapy is trying to harness our immune system. The one thing we do know is that the immune system is probably the most effective cancer-fighting mechanism that's available to us. Part of what our immune system is doing on a regular basis is looking for cells that have gone wrong. So cells that start to grow abnormally. Because of that, our immune system innately recognizes those cells as foreign. And because of that, kind of goes through a whole cascade of different mechanisms to find those cells, and by finding those cells, attacking those cells so they can never get to a point where they become a tumor or they turn into a cancer. So our immune system does a very good job of that. What happens, though, is that the cancer cells start to develop mechanisms to avoid our immune system. And the reason why cancer cells can grow without our immune system being active is because they can develop different defenses against that. So the key to immunotherapy is really how can we get the immune system to again recognize those cells as foreign. So identify them as abnormal and mount a defense against them. The key and crux of research has always been, what are the specific ways that cancer cells are different from normal cells? So that's not just immunotherapy, but that's cancer research in general. In lung cancer, we look at various mutations inside of cells. What are about those mutations help us figure out what's going to treat those patients better? We have excellent therapies, and there's some great resources in the back talking about targeted therapies, pills that can be given for certain lung cancers where patients can do remarkably well. There's also different types of mutations beyond that where we are also looking to say, is there something about that cancer cell that makes it more susceptible to one treatment versus the other? So really trying to find the way that cancer cells avoid or escape detection from the immune system is the crux of immunotherapy. Taking that to the next step, how can we then make our immune system either recognize those cells as foreign and then stimulate your own immune system to help take an aggressive role in killing the cancer cells? So that is the crux of immunotherapy. So we hear, if you visit an oncologist, we talk about, here's the chemotherapy. Chemotherapy kills rapidly dividing cells. Or we have a targeted therapy that's going to go inside of the cell, block that mutation so the cancer cells can't grow and die off. This other approach is really looking at what is it in ourselves where we can stimulate something in ourselves that can kill off these cancer cells. So it's generally a less toxic way of treating patients and can be very effective. So what are the different ways that immunotherapy is used for lung cancer? So lung cancer is typically divided into two major types of cancers: non-small cell lung cancer, which is about 80% of the diagnoses that we make, and 20% are about small cell lung cancer. So the way that we're using immunotherapy in lung cancer right now has been mostly in patients who've had prior treatments and have failed those treatments, and their cancer has come back either locally or distantly. And we're using chemotherapy, sometimes in combination with immunotherapy as a lone agent, or immunotherapy with other immunotherapies to fight the cancers. So the amount of research that we're doing in this is remarkable just because we're looking at immunotherapy in all stages of lung cancer. We have active trials where we're actually combining immunotherapies before surgery and looking to see what the responses are. Can we shrink these tumors down? Can we stimulate the immune system to recognize them as foreign and continue that after somebody has surgery or radiation therapy? So the amount of research that's going on is remarkable, and I think it's really changed patients' outlooks and survival in a really meaningful way. The crux of immunotherapy right now is what are called immune checkpoint inhibitors. So immune checkpoint inhibitors are basically medications that are trying to prevent the tumor from putting on the brakes of recognizing our cells, our cancer cells as foreign. There really are several treatments that use this approach. They include medications like anti-PD-1, anti-PD-L1, and anti-CTLA-4 antibodies. Again, they all get back to the crux of how can we make our immune system recognize the cancer cells, and then how can we arm our immune system to help it fight better. The main treatments that are out there that are available to almost every patient with lung cancer at this point are PD-1 and PD-L1s. Basically what they're doing is they're targeting an immune checkpoint found on T cells. So cancer cells, specifically lung cancer cells, and many other cancer cells. So when I talk about immunotherapy, we were talking about lung cancer because that's where it's really made the most difference. But the amount of treatment options in a lot of other tumors that I treat is remarkable in terms of what we use immunotherapy with. So cancer cells, including lung cancer cells, really produce and express this PD-N1, and this really allows them to hide from the body's immune response. So what happens is that they've developed medicines that are antibodies against that protein. And by doing that, it blocks the cancer cell's ability to shield itself from the immune system. So that's the crux of how immunotherapy works. Not everybody's cancer is going to respond to these antibodies, but when patients respond, they tend to seem to last much longer than conventional therapy. That's the impressive aspect of immunotherapy, which is if patients have a response to immunotherapy, typically patients will continue to have a response long term. Probably has something to do with we've primed the immune system to stay active. And there's reports even from some of the earlier trials in immunotherapy where patients had side effects from the immunotherapy after a few months of treatment, and they had to come off of the treatment because of the side effects. Yet, even being off of the medicine, the immune system was so primed that their cancer stayed in excellent response for a long time. Those are the earlier trials. We've gotten much better at treating the side effects and recognizing what's a severe and not severe side effect from immunotherapy, but it's remarkable that if you can stimulate the immune system, patients who had a prognosis that was measured in months, patients are living years at a time here. And I'm not talking about, limping from one appointment to another. I'm talking about when can I schedule your treatment in between your trips to wherever you're going next. So it's just remarkable on how well patients can do now. Like I said, as a lone single agent, they work very well. Even more research has shown that even combining them with traditional therapies like radiation therapy and chemotherapy, patients can do even remarkably better. So it's really opened up the way that we're looking at it. And right now, immunotherapies are really being looked at a lot of cancers and approved in a lot of different cancers, including melanomas, kidney cancers, head and neck cancers, liver cancers, blood cancers, bladder cancers, and many other tumors. If there is a way where we don't have good enough treatments, immunotherapy is being looked at. All right, so it is Saturday morning. Saturday morning to me as a kid meant in front of the TV with a sugary cereal, as my parents were still asleep and I was the one watching TV. So cartoons hold a special place in my heart, and even throughout my medical education, I remember thinking about, well, how is this working? When we talk about physiology and how the body works, I would come up with a story in my head to say, well, how does this work? And by understanding it that way, it really helped me understand the concepts. And then when you have that framework, you're able to actually talk to your patients about what is it that we're doing. So what we have here is we have a good, healthy cell. We like him. Cancer cell, very ugly, and we don't like him. Here's our fighters, the immune system, and here's super immunotherapy. I did lift this from a patient education piece, so I just wanted to throw that out there, but I did not draw this myself. So, as we talked about our immune system right here. These are our defenders. They have their little lasers, whatever it is, and here's some cancer cells here, and they are basically killing the cancer cell. Here's one dying here, here's one's about to die, but here's our normal cell, which is acting and being avoided because it's not really expressing anything to our immune system that suggests that it's bad. As you guys know, there is something called autoimmune diseases, where our immune system actually starts to attack healthy cells. That can be, seen in various other specialties, but for our sake, the immune system is being very safe and keeping our body out of harm's way. So, what has happened now? What we have here is we have a normal cell. But underneath this cover, you can see the cancer cell there. They've put on a PD-L1 coat. So this is what is blocking them from the immune system. And we have our immune system who is on the lookout here, trying to find those cancer cells like they were doing before. They cannot see this. Here comes immunotherapy. He's got some big muscles here. It is Saturday morning, so he looks like an egg, so it's perfect. He is ripping off that PD-L1, which by doing that, our immune system appears to get primed, and because of that, again, recognizes this as foreign and helps start to recognize other cells that are foreign too. So that is the crux of immunotherapy. I just wanted to give you a brief overview. You hear about it, you don't understand it. Hopefully by kind of visualizing it, it gives you a good idea of what we're doing. When we talk about things like chemotherapy or targeted therapies, we're going inside of the cell and trying to kill them with chemicals or different types of small molecules. This is actually trying to use our body to help us fight that aspect of it. So that is the crux of my presentation. So I really appreciate your guys' time.
Thank you. All right, we will now have Dr. Ferguson.
Thank you so much. A little bit of background about me. I've been a Hinsdale resident for 30 years now, and I'm just a couple of miles down the street here. I thought you found me because I was local. And I was so happy to be invited here because I've known about this facility for decades, but this is my first chance to visit. And I've had colleagues and friends use this, and it's a tremendous resource for the community of cancer patients, cancer survivors, and relatives and friends of all of those people. Just out of curiosity, how many people here are cancer patients or survivors? How many are family, friends? How many came just for the free breakfast? And Raj, thank you for the cartoons, because this is the first time I've understood what immunotherapy is about. You have to speak to the lay people to get to the surgeon's attention. So Raj already went over some of the statistics here, 240,000 new lung cancers annually, about 140,000 or 150,000 deaths from lung cancer. So this tops the combined mortality of the next 3 cancers in the U.S. So it's a very important problem. You can see that most of the patients will have advanced disease, distant disease, and the 5-year survival, of course, is quite poor for those patients with distant disease, but not too bad for patients with localized disease at the time of therapy. But this is a whole range of problems that require a team approach. So we have, as do many institutions, weekly meetings in which we introduce new cancer patients and talk about patients whose treatment is challenging. At our institution, we've had this at 8 o'clock on Wednesday morning since 1973, so it's a very important investment of our time and success in these managements. And you can see the number of different specialists that are involved in the management of cancer patients. So it's important to have a group like this involved to get all the different opinions and inputs and so on. The result of the staging and survival suggests that the number of patients undergoing surgery, about which I'm going to talk today, is probably less than 25%. Maybe 25 to 30,000 patients per year will undergo resection for lung cancer. Everybody else gets radiation therapy, chemotherapy, immunotherapy, targeted therapy, or a combination of these things. So I'm really talking about a relatively small subset of patients with lung cancer. And these guys here are the ones who do most of the heavy lifting in treating these patients. So as surgeons, we're involved in a variety of different endeavors in diagnosis and management of these patients. I'm going to speak primarily today about diagnosis, staging, and curative resection. And if there are questions during the half an hour period at the end, we can talk about some of the other issues that we're also involved with. So we're the people that frequently see the patients at first. They're referred from internal medicine, primary care doctors, sometimes pulmonologists, and so on. And we will often see a solitary nodule in the lung, such as this. This is a patient that I treated on Tuesday with a robotic resection. The job that we are tasked with is to diagnose the cancer, such as this. You can see here in the upper portion of the right lung, but also assess the stage of the cancer, the extent of the cancer. So in addition to a CAT scan that's on the left here, we'll typically get PET scans. PET scans measure metabolic activity in tumors. And so this shows the primary tumor lighting up, but also a lymph node here adjacent to the windpipe that would indicate that this patient has a more advanced stage of cancer. And it's nice to document the stage by biopsying the lymph nodes and also document the presence of the cancer by biopsying the primary tumor when necessary. So there are a number of new tools used for this purpose to assess lymph nodes, which is a fairly complex array of nodes, and our interest is in knowing exactly which nodes and which locations are involved by the cancer to accurately stage disease, both in the center of the chest adjacent to the windpipe, but also adjacent to the major vessels, the aorta and the pulmonary artery here, associated with the center of the chest. The primary new tool for this, which has been around now for 8 to 10 years probably, is a bronchoscope that has ultrasound capabilities and biopsy capabilities. So we call this endobronchial ultrasound, or EBUS, you might hear that term. So it's a standard bronchoscope with a ultrasound tool at the tip. It has a water-filled balloon so it can make contact with the walls of the windpipe. And then when you visualize something that needs to be biopsied, this needle can be passed through the wall of the bronchus into the lymph node. And this is used, I would say, in maybe 70% of our patients for staging. Now it's replaced a surgical intervention that used to be used very commonly. So you can see here the main windpipe, the bronchoscope going down. Windpipe splits into two. These lymph nodes adjacent to the windpipe are visualized with the ultrasound, and the needle is passed through the wall of the windpipe and does the biopsy. So in addition to that, there are new techniques for making the diagnosis of cancers in the lung tissue itself. This is an area that's historically been quite difficult to access short of passing a needle through the chest wall, which can be quite uncomfortable under CT guidance. It's a little too peripheral for standard bronchoscopy to get out here from all the way in here. So the new tool that's been available now is a robot bronchoscopic procedure that's just been released within the last month or two. The CT scan is put into a computer analysis system so you can analyze the individual airways going down towards this peripheral lung nodule. And then you actually use a joystick that controls the robot to drive a telescope down these airways. And the airways this can reach now are quite small. And this telescope can go all the way out to the periphery of the lung and get biopsies this way. So it's something that has not been available since we started treating lung cancer seriously in the middle of the 20th century. Now has the opportunity to get tissue from very peripheral cancers or cancers that historically have been very hard to reach. And the tissue can also provide information about the markers that will help decide appropriate treatments for these patients. Now, from a surgical perspective, what we are tasked with typically, a standard operation, is to remove a lobe of the lung. On the left side, that would be the entire upper lobe or entire lower lobe, 50% of the left lung. On the right side, it could be the entire upper lobe, lower lobe, or middle lobe. Those represent slightly different percentages. And this is somewhat more complex if we start to think about lesser resections. I'll talk about this more in a minute, but each lobe is made up of different segments, as you can see here. So the anatomy is a little bit complex, and just to illustrate this further, you can see branching of the windpipe here. And we're tasked with knowing the names and locations of each of these branches. This seems reasonably straightforward until you overlay that with the arteries that come out of the heart and interlace with the bronchial anatomy in 3 dimensions. And then, of course, we have the veins that we have to worry about. So if we're operating out in the periphery of the lung here, you can see that without some training and experience, finding the right thing could be a little challenging. The other problem is that it's not color-coded when we look inside. So a typical operation historically would be done open, and we would isolate the portion of the superior pulmonary vein here that feeds the upper lobe, preserving the portion that drains the middle lobe here. And then fortunately, for the last 20 years or so, we've had staplers that automatically close and divide the vessel. Previously, we did clamp, cut, so. Hopefully the stitches will hold. This is much more efficient, and it's quite safe. And then once we get the artery divided, you can see the cut edges here, the vein, then we attack the branches of the artery here and put a stapler across. There's usually several branches of the artery to a lobe. And then once we finish that, we cut across the lung tissue and remove that portion of the lung. So what's new now is that we're seeing much more commonly small and peripheral tumors amenable to lesser extent of lung resection in order to cure the cancer. You can see that a typical site for segmental resection, sparing the rest of the lobe, would be the apical segment here, superior segment here, or the basilar segments here, sparing the superior segment, similarly on the left side. So understanding this segmental anatomy now is quite important in permitting us to do, instead of the original operation for lung cancer in the 1940s, take out the entire lung, the standard operation from the 1950s until now, taking out a lobe of the lung, is to take out a segment of the lung for appropriately selected patients. This obviously helps preserve lung function and provides a better long-term quality of life for these patients, assuming that they are appropriately selected for this lung-sparing operation. So the other advance that's taken place in the last 15 years, but it only reached acceptance in the last 5 years or so, is robotic resection. So since the middle of the 20-aughts, we've been doing minimally invasive lung resections. We call VATS, video-assisted lung resection. And we use straight instruments like this put through small ports between the ribs instead of long incisions to get at the lung. This is a little challenging because these instruments are rigid and just have one small working tip. But I'd say currently 80% of our lung resections are done using minimally invasive techniques. So you're using either 3, 2, or 1 small ports like this. But this is challenging because of the lack of flexibility of the tips of these tools. What's the advantage now in robotic surgery is that the tools have fully articulated tips. So they're even more facile than the human wrist in getting at the tissue. It has 8 degrees of rotation. And these instruments are attached to a large machine, such as this. This is the newest version of the robot. So you can see a big stem here and base that we wheel in over the patient. There are 4 robotic arms, each of which is individually controlled by the surgeon. So when we think about the robot doing the operation, this is not one of these. It's not automated. It's the surgeon sitting at a console and operating these tools individually. The way this is set up then in the operating room is the patient is lying on the table here, the robot's positioned over the table, small ports are used so the instruments and camera go in. There's a bedside assistant that changes out the instruments for us when necessary. And then typically we have a console and a teaching console so we can have trainee assist in the operation for appropriate portions of the operation. I like to think that this is me here. This guy's a little too chubby. And now the penetration of this into surgery is maybe about 10%. So robots are becoming very common in a variety of surgical and gynecologic specialties. I would say we're doing about 50% of our operations robotically now. In urology, probably 90% of the prostatectomies are done robotically. Much of the gynecologic surgery is done robotically. So the resources for this are quite expensive. The robot's about $2 million each. We have 4 robots for the operating room, 1 research robot, 1 teaching robot in our institution, and that's not unusual for medical centers to have that much resources. So the other thing that's fairly new now is a program, this is non-technical here, there's no toys here unfortunately, a program of enhanced recovery after surgery. This is quite important for improving surgical outcomes, patient experience, return to full capacity, and it involves a variety of different components. We're introducing this not for chest surgery, we're introducing this hospital-wide, so every service that does surgery now is going to have, for the vast majority of their patients, entry into this type of a program. So the first component of the program is in the preoperative period, and the most important component of it is educating the patient and the patient's family or support group about what's involved in their recovery from the operation. The process begins with limiting the amount of time the patients are without food and water. So as any of you who've had surgery know that You have to fast after midnight, even if your operation's at 3 o'clock the next afternoon. So you go in feeling hungry, crabby, dehydrated. None of those things is good for a good recovery. So typically we'll stop solid food after midnight, but now allow liquids until just a couple of hours prior to coming to the hospital to have the operation. So if the first operation starts at 7:30 in the morning, patients are allowed to take clear liquids until about 4 a.m. We are doing routine exercise. So every patient that I see, the first time I see them, I ask them to start doing an exercise walking program. I ask them to walk vigorously for a mile or two every single day. We have a grant that was just approved yesterday for us to begin exploring a high-intensity, short-term exercise, HIIT program, for our preoperative patients that's going to last for about 2 weeks and have supervised exercise 3 to 5 times per week to get them in better shape to have an operation. And then the other thing that's very uncomfortable for patients who are having abdominal surgery is the bowel preparation. Most of you have had colonoscopy and so on. You know how uncomfortable that can be. And most of the patients that are having surgery can avoid that entirely. Now, the real magic happens during the operation. So most of these patients should have minimally invasive surgery as opposed to open incisions. That limits pain, but it also limits the amount of inflammation that is caused by the operation, and that facilitates more rapid recovery. Maintaining the body's temperature allow all the mechanisms that make us work to function at 100%. When patients get cold, their bodies tend to shut down a little bit, and it takes a long time for them to recover again. We found that historically, we give way too much intravenous fluid to patients having surgery. We want to make sure they're making a lot of urine and so on, and that turns out to be deleterious to patients. So we're very judicious in how much fluid we give patients. And then we preemptively medicate everybody for nausea and vomiting, which can often happen as a result of the anesthetic or the pain medicines that are given after surgery. And this is important because we really want the patients to be as quickly as possible back to oral intake, eating regular food. This is facilitated by avoiding using narcotics in the perioperative period. So we have about 5 or 6 classes of medications that we give routinely for pain management perioperatively that don't include opioids. Patients are encouraged, and I use that word in quotations because often they're forced to get up and start walking after the operation. So my first experience with this early ambulation was after an 8-hour removal of a patient's esophagus. He happened to be a priest who was 89 years old. We finished at 4 o'clock in the afternoon, and at 6 o'clock in the afternoon, he was walking in the hallway outside of his intensive care unit room. And so this is quite important in ensuring that patients stay relatively conditioned after their operation. Mobilization helps prevent getting blood clots and pulmonary embolism. And it's also very good for their attitude. Now, the last thing I'd like to discuss for just a couple minutes is the concept of frailty and sarcopenia. And we'll define these things in just a minute, but it's related to the aging population that we see, not just in the United States, but around the world. You can see the percentage of patients here who are older as we get another 20 years from now is going to be 20%. These are the patients that have cancer. We need to figure out how to manage these patients optimally. Now, frailty is on the percentage of patients who are frail increases as age increases. So as we get to age categories of 85 to 89, almost 40% of these patients will be so-called frail. And that has a very important negative impact on outcomes after surgery, but these concepts also apply to how patients respond to radiation therapy, chemotherapy, targeted therapy, and immunotherapy, and concepts that can be applied just not to surgery, but also to all aspects of cancer care. So frailty is defined as increased vulnerability to stresses. Obviously, surgery is a major physiologic stress, but any of the other treatments also are quite stressful for patients. Frailty is often, if not always, associated with sarcopenia. Sarcopenia means loss of core muscle mass. That doesn't mean just weight loss, but often does. But you can have someone who's extremely obese, but is also sarcopenic. They're very heavy, but they have no muscle mass. Some of the patients who are frail also have dementia, so memory problems, and behavioral problems. Not always, though, but those are often linked. So in the community, people who are frail often will experience falls, and falls are what lead to hospitalization and ultimately mortality. Patients who are or people in their 70s, 80s, and older, the single most important thing they can do is avoid falls at home. Now, when we're talking about surgery and we recognize frailty in a surgical population, you can see that they experience increased complications, increased duration of their hospital stay, often are discharged to a nursing facility as opposed to home, and it's associated with a substantial increase in costs of care. Now, fortunately, surgeons are pretty good at recognizing patients who are frail. If we compare the surgeons in orange here to the geriatricians in yellow, the surgeons and geriatricians are able to classify the degree of vigor or frailty very similarly. And we have accomplished this usually through experience as opposed to through training. So what we do is observe patients when we first meet them and how they interact with us and with their families. We look at how they walk, how they mentate and how they interact with us, whether they have problems with strength or balance, whether they're demented. And then we ask key questions of the patients and their families about their energy levels, what their type of exercise is, whether they've lost weight, and so on. And it was kind of interesting. I saw a patient who had been operated on in another facility, and her surgeon had retired, so she came to see me and my team for the routine follow-up that's supposed to occur after lung cancer surgery. And she met one of my physician assistants, and then I went in to see her, and she said, I can't believe how different the experience is here. Nobody ever asked me questions about what I do for exercise or how active I am and so on, but these are routine metrics that we assess in every patient that we see who may be a surgical candidate. What we found in screening our patients in my clinic is that 70% of patients are either pre-frail or frail who are sent to me for consideration for surgery. That's a very high percentage. And you can see as the patient's age category increases towards older age, the percentage of patients who are pre-frail or frail becomes very high. So in this older population, we have to be quite cautious about how we manage them. So if we identify pre-frailty or frailty, we generally recommend that these patients undergo a comprehensive geriatric assessment by a specialist. And then we can ensure that we use this enhanced recovery pathway if we do decide that they're appropriate candidates for surgery. We may decide to limit the approach to the operation or the extent of the operation. So as opposed to taking out a whole lobe of the lung, we may do a smaller operation. If we were planning open, we may do a minimally invasive operation, or we may think about an alternative treatment. You'll hear about SBRT here momentarily. And so for patients with isolated early stage lung cancers, that may be a perfectly good treatment for somebody who is not an optimal candidate for surgery. And then we consider prehabilitation. This is this exercise program prior to any operation that we would like to use more commonly. And then when we have all this information about level of risk, what we can do to decrease risk and so on, we have a fairly detailed discussion with the patient and their family and share with them in the decision-making about the process. Now going forward, we're going to have a lot more ability to accurately assess frailty as well as sarcopenia through some anthropomorphic and laboratory measurements. This is research that we're working on currently with colleagues at the University of Michigan. The standard CT scan can, in a semi-automated fashion, be categorized as to the amount of core muscle, and the body is also subcutaneous fat, visceral fat, cortical bone density, trabecular bone density, a number of different metrics. And we've used this now to create a morphomic index, which predicts the potential for postoperative complications, as well as predicts longevity in patients undergoing surgery for lung cancer, doing similar work in patients with esophageal cancer now as well. But there's also the opportunity for laboratory data to contribute to the diagnosis of frailty. We think of frailty now as a syndrome of chronic inflammation that affects the nutritional system, the endocrine system, and the immune system. And we're beginning now to identify some markers that can be routinely collected to add to the accuracy of our diagnosis of frailty, and then how to intervene to reverse that, to make it much more possible for patients to get aggressive therapy for their cancers. So in summary, this field is becoming increasingly complex, but also we're much better able to help patients in deciding about cancer treatment after the diagnosis and staging are performed. I'm really very high now on the robot, and the next generation of robots is going to have some very remarkable abilities that will actually improve the surgeon's capacity to do successful operations. And then finally, a topic that's broader than just surgery alone, frailty. Screening is going to become important, and methods of intervention for frailty, I think, are going to be seen just around the corner now. So thank you very much for your attention.
To our final panel presentation with Dr. Maraha. Thank you.
Thank you. You guys hear me okay? There you go. All right. So it's an honor to be here. There's nothing I enjoy more than speaking to patients, so both in the clinic and outside of the clinic, and hopefully offering some education as to how far we've come with radiation therapy over the years. And specifically, in the treatment of lung cancer, SBRT has just had this tremendously evolving role that we've learned a lot of just incredible things about, even in just the last year. So I'll be sharing some of those updates with you today, and there'll be plenty of time for questions. So objectives is really just to kind of get a little 101 on radiation and what exactly it is and what SBRT specifically involves. What are the current indications for SBRT in 2018? And what are some of the expectations after treatment with SBRT in terms of cancer outcomes, side effects, how we do follow-up, and then we'll have some time for questions too. So here is my one slide to explain what radiation is. So what we know about it is that greater than 2/3 of cancer patients in general at some point in the course of their therapy receive radiation. I suspect that between chemotherapies and surgery and radiation is probably the least well understood amongst most of our patients, but also many of our medical staff as well. So classically, radiation involves daily treatments using X-rays that occur Monday through Friday at most centers, sometimes weekends, but usually not. X-rays specifically are used largely in medicine, primarily for diagnostic purposes. But what I tell all our patients is that it's really, we turn up the noise on those X-rays, focus them really well, and they can actually cause damage to DNA, specifically cancer DNA. And that's what helps destroy, ultimately, cancer cells. So if you guys were ever kids or maybe adults and you took a magnifying glass outside into a hot sunny day and you kind of angled it just right, you could fry a blade of grass, or maybe you'd kill an ant if you felt so violent. And so really the analogy is not just to sound foolish, but it really is actually the principle of radiation therapy. So the sunshine is a form of radiation. It's ultraviolet radiation. And we use X-ray radiation in our field, which is sort of like a cousin to ultraviolet radiation. And what we do is we harness high energies of radiation, and we kind of shoot them through a very small gap in our treatment machines. And we aim that preferentially at the tumor. So with that being said, let me introduce you to SBRT. And I think really the key with SBRT is, and perhaps many of you guys have heard this term or heard about different technologies. Really, there's not one machine that makes something SBRT. There's not one person that makes something SBRT. It's really a platform for delivery of radiation. And within that platform, there's a lot of different variables that need to be optimized. A lot of radiation machines can be optimized to deliver SBRT, but it's not even just that. There has to be the right personnel around that machine, support from medical physicists that understand the principles of SBRT, and ultimately a number of things that we do to make sure that we are extremely, extremely precise when we use this treatment technology. And that's really sort of the buzzword is precision, and that's being able to target a tumor in multiple dimensions with real-time imaging to kind of help make adjustments as we go. And typically this is done in just as little as 1 to as many as 5 treatments. So very different than the classic radiation of back and forth for several weeks. So that's sort of what's become synonymous with the definition of SBRT is really a short treatment course. Logistics for delivery of SBRT, it all starts with a fancy CT scanner where we make a map of the area we want to treat. And we use that opportunity to do a few things to make sure that our patients can be comfortably positioned for their treatments. They can be effectively immobilized. In other words, because of the precision with which we're using this technology, we have to make sure patients aren't wiggling around during their treatment. So we make what I like to call our version of a Tempur-Pedic mattress for our patients. It's really just a air-filled beanbag. Suck the air out, it kind of molds to the patient's body. We have some contraption over the top to kind of restrict what we call diaphragmatic excursion, or the diaphragm which moves up and down during breathing. We try to put a little pressure on it to reduce the amount of motion that may be happening in and around the tumor. And then we acquire something called a 4-dimensional CAT scan. So the 4th dimension is time. So we look at patients as they kind of breathe in and breathe out, and we take a video of their breathing. And that helps us understand anywhere that tumor that we're aiming at could be during the treatment course. Patients typically get tattoos. These are just little freckle-looking things that help us really triangulate or better aim our treatment. Treatment planning, this is sort of the real behind-the-scenes work. Sort of our version of our operating room, I guess. But we use various softwares and technologies to map out the tumor that we want to treat, map out all the areas that we don't want to treat, and then we work with our team of physicists and dosimetrists who are sort of like the pit crew in our department, if you will, and they help us generate treatment plans. So this usually takes us about upwards of 2 weeks. The delivery of radiation then would start. Again, it would be 1, maybe 3, maybe 5 treatments, and we have a specific machine commissioned to do this. We have therapists that will help put our patients in the perfect positions, and then we as the physicians will verify those positions using several sets of checks. At Rush, which is where I practice, we have a machine that actually zips around the patient pretty quickly. So we can actually treat tumors in under 3 minutes. However, we tell people that allow for 20 to 30 minutes total per treatment because we spend most of the time getting people perfectly aligned. Rule number 1 in our world is to do no harm, but rule number 2 in my field specifically is not to miss. And so we spend a lot of that time kind of making sure we're hitting exactly where we want to. So that's a little overview of what SBRT is within radiation. In terms of what are some of the indications of SBRT, well, we know that we can use it, and it's sort of become the de facto standard of care for patients who are medically inoperable. So, and they have an early stage non-small cell lung cancer. There's also some evidence started kind of in the Japanese patient population, and we've had a few trials in the United States as well that suggest that it can be effective for patients that are operable as well, who may refuse surgery for various reasons. There's some stage 2 non-small cell lung cancer patients that can also be effectively treated with SBRT. Probably the most exciting development over the last now about 2.5 years has been the use of SBRT for the treatment of something known as oligometastases. And so this is a concept that by definition, if there's cancer cells that have left the lung or moved to other parts of the body, the person's stage goes from an early stage to a locally advanced stage to now a stage 4. So it's metastatic. However, within metastatic lung cancer, there can be something known as an oligometastatic state, which means there's just maybe a few areas of cancer outside of the area where this all started. And so there is now data, evidence to support using SBRT to help what we call consolidate, which is a kind of our fancy word for patients have had systemic therapies, be them chemotherapies or immunotherapies, and then they get new sets of scans, and the scans may show that, well, there was a few areas that responded, but they're not fully been destroyed. We can use these targeted radiation techniques to destroy those areas. And then there's also this concept of oligoprogression or isolated progression. So maybe a patient has had a great response to chemotherapies and or immunotherapies, but maybe there's one area that actually grew despite those therapies. Well, we oftentimes in that case will say, well, instead of switching chemotherapies, why don't we use this localized therapy of SBRT and try to destroy that spot as well. So there's more and more indications for SBRT. A couple examples of treatments that we've done. This down here is a left adrenal gland metastasis. So the adrenal gland's kind of responsible for the secretion of steroids for the body, and they live right above the kidneys. So on the left side, here's the kidney here, the adrenal gland is right here. This patient developed a spot in the adrenal gland and was treated with SBRT. Patients also can develop disease within the vertebral bodies of the spine. You can kind of see normal, healthy white bone here, but then there's So this grayed out area, which is tumor cells, we can target with radiation and avoid the spinal canal very, very effectively, which is right here, and offer really good results with SBRT. And then here's a scenario where there was a tumor that had progressed in the liver. And so, another area of the body that we can use SBRT very effectively. Some of the investigational aspects to SBRT include, in an effort to try to improve outcomes in patients with stage 3 non-small cell lung cancer, there's been a few different experiences that have studied the use of SBRT to boost or give a little more punch to the tumor after patients get chemotherapy and radiation, specifically for patients that aren't going to go on to surgery for their cancer. And then alongside immunotherapy, Dr. Malhotra shared with us a really nice overview of immunotherapy. And I think part of sort of figuring out the next frontier, if you will, of radiation therapy is really understanding how does radiation interact with the immune therapies. What we're learning now is that radiation therapy can help prime the immune system and make immunotherapies more effective. We've seen it in certain cancers like melanoma and certainly in lymphoma, and I think most recently in lung cancer. And it's been really exciting to see that actually that sequencing of radiation and immunotherapy, which probably involves giving radiation first, followed by immunotherapy, or maybe even combining them at the same time. Combining them at the same time is currently under investigation. It's not a standard. In small cell lung cancer, we have some evidence that using SBRT, either in an oligometastatic scenario or in patients who have a very, very early form of small cell lung cancer that aren't going for surgery, we can use SBRT effectively as well. And then I bolded this repeated usage. This is something that was completely thought to be crazy maybe even 5 or 6 years ago. Someone who's had SBRT and then everything else looks good, but the cancer comes back right where we treated it. Fortunately, that risk is pretty low with the right treatment course. But we've learned that in select patients we can actually repeat SBRT, and so that is something that's exciting that we can do safely for some people. In terms of how do we do is really a bit of a complicated question because we define things differently maybe than we talk about surgery and local control and radiation and local control. They're kind of two different concepts because we're using the terms local control differently. But in the spot we treat, we do really well if it's a early stage non-small cell lung cancer. For tumors that are a little bigger or infiltrating, let's say the rib cage, our control rates are a little worse. Our control rates will never be as good as surgical resection, and so we understand that we're compromising something, but part of the reason for that is we're really just treating the tumor we see. We're not removing additional tissue or destroying additional tissue around the edges of that tumor. And then in terms of oligometastases, whether we're treating with SBRT in the liver, the adrenal glands, the spine, a lot of that disease control comes down to how much dose we can give, but really what type of cancer is it? And that can help dictate how good we do. But I usually say that we're somewhere 80 to 90% good in controlling those areas. And a lot of that is influenced by what form of systemic therapies the patients may or may not be receiving. What we do know, however, and this was just sort of updated at our national meeting in San Antonio a couple weeks ago, ASTRO is the name of the meeting for our field. And this was a study that was a combined study from MD Anderson, a group in Canada, as well as the University of Colorado, that when patients are selectively chosen to get SBRT or surgery, actually, for these oligometastases, there can be a dramatic improvement in their overall survival. So the first study to show that not just the ability to kind of slow down progression or improve quality of life, but their overall survival can be dramatically different. And actually on that study, there was a doubling of overall survival. So pretty exciting stuff. The paper should be available, I was told, by next month. In terms of follow-up, really this is extremely important. So, you know, a patient has surgery, the tumor is removed, it's sitting in a jar somewhere, the cancer's been controlled. In our world, the analogy I like to use is, you know, instead of sort of, if there's a living bug, if you will, in the chest, and we're calling that the tumor, instead of taking the bug out, which is what surgery would do, we're sort of stepping on the bug. We're squashing it. We're making it not alive, ineffective, dead tissue, but we're always going to leave some sort of smear to kind of show you that we've been there. And so understanding that smear, or the changes in the scar over time, is really important. And that's where it really does take a multidisciplinary team of experts who are trained in following patients after these treatments to understand what is truly an expected change after radiation versus an unexpected change. So we use CT scans as our best friend to help us do that. We don't use contrast for those, so just a regular CT scan. Only if we have any concerns or questions about what the CT scan is showing would we use any advanced imaging, like a PET scan. And so we do our follow-up in a multidisciplinary way. So, you know, one of the reasons we don't use PET scans routinely to follow up after these treatments is that radiation can create a lot of inflammation in the body. And if we look too soon, or really at any point within a year of that treatment, we may see what we call false positives. In other words, we'll see a reaction that makes us chase our tail as opposed to really learning something from a PET scan. So we tend to avoid using those routinely. And then, you know, patients who may be getting scans at other hospitals or, you know, with other groups, we always say, well, we'd like to have all that information under our roof so we can interpret them and compare, you know, the scans we got at our institution with the outside, and hopefully help make clear of the situation that maybe one doctor says, oh, it looks like the cancer's come back, or another one says that it's not there. So we look for internal consistency. Side effects, fortunately, are very minimal with SBRT. However, it does depend on location. And specifically with lung SBRT, very well tolerated. Most patients get at least a touch of tiredness and what we call asymptomatic, or you don't feel it, but there's inflammation in the lungs. We see it on imaging. And then rarely can we cause skin irritation, chest wall pain, or rib fracture, or kind of neuropathic pain, or symptomatic pneumonitis where people feel shortness of breath or develop a cough after the treatment. We recently reported our experience in treating what we call very elderly, although I think the definition of elderly seems to be shifting every year. It might be 90 now. Probably next year it'll be 95. And so we had a really nice experience where not a single patient developed a side effect that they could feel other than mild fatigue. So we do like it, and patients seem to like it a lot too. In terms of abdominal SBRTs, this would be the treatment of a liver metastasis or perhaps an adrenal metastasis. There's going to be some increased risk of injury to the bowel, and so that can cause nausea, sometimes a loose stool, but rarely anything that's a long-term complication. Musculoskeletal SBRT, so treatment of metastases that are in the muscle or the bones. One of the risks with SBRT is that we can cause an increase in inflammation that creates pain. And so we usually protect or prophylax patients with a steroid to help reduce or offset that risk. The chances of us causing something like a fracture, fortunately, are not significant. However, if the bone that we're treating is already, let's say, on the verge of a fracture or compressed, then that risk can be reasonable, maybe about 20 to 30% in those patients. So just a few examples. We recently, in the last couple of years, had this 93-year-old lady who had underlying COPD. She was requiring oxygen. She was not deemed to be an ideal surgery candidate. And she had something known as what we call synchronous primary non-small cell lung cancer. So there was one stage 1 lung cancer in her left lung and then one in her right lung. And so as we do with all of our new patients at our institution and most institutions as well, we discussed our patients prospectively at our multidisciplinary tumor board. And SBRT was offered for this patient given her level of frailty. And so we see here is a tumor in the left lung here and right lung here. And both of those areas were hot on her PET scan. Over time, after SBRT, the spot was destroyed. We get a reaction here. On the right side, you can see maybe a little less of a reaction here. The spot was destroyed. So this lady is about 1.5 years now, doing well. She sings in her church choir, performs all her daily activities, feels that her breathing has not changed since being treated in this fashion. We do follow her every few months with CT scans. Another example, really to highlight, I guess, we do see a lot more younger patients with lung cancer these days, and a lot of them, fortunately, have what we call targetable mutations. But that being said, they often present with stage 4 disease. And so we had a patient who had been very well treated on targeted therapy. The patient had what's known as an EGFR mutated version of non-small cell lung cancer, and had been doing quite well for some time, and then developed one area of activity in the left upper lobe of his lung. And so the decision after a meeting in our conference was to offer targeted therapy and continue the patient on their current targeted therapy. So at the time of planning, this is what the tumor looked like. 2 years later, this is what we see, sort of this scar formation, or what we like to use the word fibrosis, which is just a fancy word for kind of the pattern of scarring that happens after radiation. And the patient continues to do well on the same systemic therapy that he was on when I had met him. Most recent PET scan was negative, and he continues to work full time. And I think this highlights an example of really a philosophy of care, which is you stick with what works. You have a systemic therapy that's working really well. And if we see something that's starting to act up, we target it. We could target it with radiation. You could target it with surgery as well. And what it does is it gets more and more mileage out of that systemic therapy, and it creates more potential options. As you know, every day we learn of a new drug or a new medication that comes out. So it may actually buy patients time to see another drug or to have a few more options in their management. And we can do it with a very low toxicity profile too, which is nice. And so just one more example. This is a patient, 65-year-old male with a stage 4 non-small cell lung cancer who developed progression in her liver, in his liver, I should say his, discussed in our conference, and PET scan was requested to confirm that indeed this was progression. And so it did show this spot at the top of the liver, the dome of the liver here on the right side. And so it was targeted with SBRT. And this is sort of a color chart to signify how much radiation dose is being given. You can see the hottest area is red, and then it kind of cools off, yellow, green, blue. And then pretty much when you get to this area here, there's a dramatic fall off. There's virtually no radiation meaningfully being distributed to the tissues. And this is the patient's heart, so we had to be very careful to kind of avoid giving any undue amount of treatment to the patient's heart. And that's why you kind of see it's a little hotter further away from the heart, and then it starts to cool as we get closer to the heart. And so these are some of the strategies we use to deliver a very effective therapy with minimal complications to nearby critical structures. So the patient did experience some nausea. This was treating the liver. And so we did have to give the patient some antiemetics or anti-nausea medications. But fortunately, I was able to resume on systemic therapy. And then 1 year later, overall was doing well. The liver looked good. And then it was the adrenal gland, interestingly, that started to act up. And so that area was also targeted with SBRT. The patient tolerated that extremely well and now continues to do well, remains on systemic therapy. I can't highlight this enough, but within our department of radiation oncology, and really any department of radiation oncology, there's so many people. I've kind of highlighted as therapists, as nurses, there's these dosimetrists and physicists. For every single patient that walks into our department, it takes a whole village to deliver that one treatment of radiation. So extremely team-based model in our department. But kind of taking that to the higher level, and Dr. Ferguson shared a similar slide, every single patient case that I described, was discussed in our conference. And who is that conference made up of? It's all these people. And we have to sort of huddle up and keep the patient the center of our focus as we discuss each patient's case, and so that it's not just one person making a decision. The concept is more heads is better than one, and I think cancer care is really sort of the epitome of that model. And that's about it. So, thank you.
All right. Well, this now brings us to, we're ahead of schedule. So more times for questions with the doctor. So I will open the floor up and I'll come around. So if anyone has any questions for our panel, raise your hand and I'll come share the mic.
Can you clarify the difference between immunotherapy and, I can't even read my writing, immunotherapy and targeted therapy?
Can I invite you to stand up? Thank you.
So immunotherapy is, like we had talked about, which is trying to target, have the immune system target the tumor. Targeted therapy actually relates more in our field to finding something inside of that cancer. That's what we call a driver mutation. So driver mutation typically means that it's one of the main focuses on why the tumor grows. It could grow because it evades the immune system, but inside of that tumor, there's a mutation that we know causes the majority of growth. And as Gaurav had mentioned, there are patients who are on these targeted therapies where their tumors shrink remarkably well. So compared to general chemotherapy, patients typically live dramatically longer on these targeted therapies. So targeted therapies are, you were looking for something inside of the tumor that you can target typically with a pill that actually can control the cancer and in a very significant way.
And when there's no tumor, they're just cancer cells?
Well, tumor and cancer cells, we get into these semantics sometimes. When I talk about tumor, it means cancer cells, so it could be scattered cells that could be elsewhere. So a lot of the times when we're treating patients, let's say after surgery, we're giving them treatments to try to find any cells that escaped beyond where the surgery was done. Tumors, are cancers basically, but they are a conglomeration of cancer cells. So, but if you're giving a therapy like a targeted therapy, you're hoping to treat every cancer cell that's in that body. But there are times when you have progression in one area, but everything else is dramatically better. And then you say, well, there's something about that area that's not doing well. It could be it's avoiding the immune system, the drug's not getting there well enough. Therefore, kind of local therapies can be very helpful in that situation. Whereas before, we would say, oh, if you have progression, it means it's going to be a progression everywhere. Because our therapies are so much better, we've kind of thrown off that, which is to say, oh, if it's progressing one place, it's got to be progressing elsewhere. Let's change our therapies. Rather than nowadays, we're saying, well, let's treat it locally and continue our therapies that are doing well for the rest of the patient.
Thank you. Any other questions from the audience?
Oh, for the same doctor before he sits down. With your immunotherapy, you mentioned that some people have side effects. What type of side effects?
Sure. So in the same way, we discussed the immune system is stimulated revved up to find the cancer cells and attack them. The main side effects of immunotherapy are almost autoimmune side effects. So the most common side effects are things that people typically don't feel that much, whereas the immune system then attacks, let's say, the thyroid gland, and you get some low thyroid. Sometimes it goes high, sometimes it goes low. You can get a lot of other different side effects. The more severe ones can include your body starts to attack the lungs, so you get what's called a pneumonitis, which is inflammation of the lungs. You can get what's called a colitis, where your immune system attacks your colon and you develop diarrhea. It's in the same realm of autoimmune diseases. So oncologists now have become very good immunologists because we're trying to figure out how do we treat side effects of our treatments. That being said, the amount of severe side effects from immunotherapy is typically less than 5%. So they happen, but we know how to treat them. We know how to get patients back on therapy. And there are times when we say, oh, if you have this side effects, it typically means your immune system is pretty revved up, and hopefully at that time also fighting the cancer at the same time too. So, from the days of chemotherapy where, everybody would have side effects and that, people can get side effects. We've become very good at knowing what those side effects are, but we know what the severe side effects are that say we have to stop the therapy.
Thank you.
Yes.
I have another question
Oh, sure.
for you about immunotherapy. Is there ever a circumstance where immunotherapy did not work despite the qualifications for it?
Sure.
Yeah.
Yeah, so, it looks great, like it should work for everybody, but there's likely in-person patients who don't respond, there's probably different ways that the cancer is evading the immune system or has developed other things that help it grow beyond what the immune system can stop. We're trying to get better to figure out who's going to be best treated by immunotherapy. Right now, if you have metastatic lung cancer, at some point in your treatment, you will receive immunotherapy. The question is, where do we put that, and how can we figure out, much like we know about targeted mutations, is there something about certain tumors that would respond better to this immunotherapy at this point versus later? So we're not that good yet, I'll be very honest with you, but every time we've added immunotherapy to the treatment of lung cancer, be it frontline or in the kind of second, third line, it's helped the majority of patients.
Well, that was the follow-up. I mean, is there ever a time when the therapy failed, I'll say, and then later it's resumed or started again, or maybe it's different?
That's an active area of research right now, which is where we're trying to, because let's say it's worked and then it stops, what is it about that cancer that has changed, and can we add different medicines that perhaps will re-stimulate an immune response or reinvigorate the body to recognize those cancer cells. So that's an active place where there's a lot of research.
Okay.
And I would encourage, if there are clinical trials available in that situation in patients who have gone through immunotherapy, find those out, seek those out. We have them at our institution, but almost every institution is looking into that active area of research.
Okay, and if it failed the first time, in other words...
We don't know that it would fail the second time.
Okay.
Is there something you can do in between them to say
Okay.
maybe it'll work again?
Okay, great. Thank you very much.
Yeah, if you are on immunotherapy and it is working, how long do you have to remain on it? Or is that unknown yet?
Yeah. If I hear this question every day when my patient's on immunotherapy, it's fun to have these questions because they're doing well. We participated in a study where we looked at patients who were on immunotherapy after they had failed initial chemotherapy. And the study was, we stop after a year versus continuing them as long as they have a response. And at least initial results suggest that if you stop at a year, there's a chance of it coming back. But in the same way, those patients can be put back on immunotherapy and still have responses. Not everybody, but they can. At this point, we don't have the right guideposts to know that. My longest patient on immunotherapy she's approaching 4 years. So, we're doing it less frequently. She has no side effects. We have a handful of patients that at every scan we're like, well, everything looks great. We used to do scans, as I'm sure a lot of you know, like every 3 months. Here's my scan. What's the next one going to show? What's this mean? We're starting to send it out because when patients feel well, as an oncologist, and all of us see it, where when patients are doing well, we know it. When they're not doing well, we pretty much know it. So I'm starting to extend my scans out when we're in their second and third year, every 6 months. I've done a scan in a year in a person because she was like, I've had enough scans. I'm feeling good. I'm fine with that. So I don't think we know that. But there's been, I'll be very honest with you, I don't know that we'll ever know that. I think the times will be, the encouraging thing is, as I had talked about, patients who sometimes get a response who need to come off of therapy can continue on responses without even getting the drugs. But we don't know that at this point.
Thank you.
Mm-hmm.
Could the panel briefly cover recent advances in the treatment for small cell lung cancer, both radiation and chemotherapy? You touched on some, but are there some really exciting things that are now blossoming?
At least from the systemic therapy, small cell lung cancer has been kind of an orphan of lung cancer. When I started training back, in the late 90s, the way that we treat patients has been exactly the same. There's been advances in finding earlier stage disease where surgery is being used. There's definitely better techniques in terms of radiation, but the systemic therapies, kind of the chemo we give, has not changed that much. The next advance has been the use of immunotherapy in that situation, and we always think that small cell tends to be very responsive to what we do, meaning it does shrink down when we treat it initially, but eventually it kind of comes back in the future. Really the role of immunotherapy is that sort of that long-term issue, which is, okay, if it does come back or starts to grow, can you then prime your immune system using perhaps a combination of immunotherapies to keep the body from keeping it under control long-term? So I think that's the most kind of present area of research there, but I think the question will be, can we introduce these other systemic therapies like immunotherapy earlier so that when we do get the response, we don't have to go back and say, oh, it came back, now what should we do now? So
that's under consideration.
it's being looked at. I think it's being used in terms of combination with radiation therapy and how can we be more effective in that. So that's where the at least small cell aspect of it is. One thing about small cell lung cancer is we think that there are enough mutations inside of a small cell lung cancer that immunotherapy should be a better fit than most of the chemotherapy that we used to give. So.
I'll just add a few things. This was actually a big year for lung cancer and small cell also. So one of the big publications that came out in the New England Journal was actually adding immunotherapy to standard chemotherapy for patients with extensive stage small cell lung cancer. So that at least we're starting to do that at our institution routinely for patients who are diagnosed with small cell that's already sort of spread through the body. So an earlier introduction of immunotherapy. Along those lines, we've learned that incorporating radiation therapy, even in patients that have extensive disease, can be a very beneficial thing. Our group presented at the World Lung Conference in Toronto earlier this year about 10 patients that had radiation therapy alongside immunotherapy and had just dramatic responses, not only in the areas that received radiation, but the other areas as well. So I think we're trying to fine-tune our understanding, specifically in extensive stage small cell lung cancer, using immunotherapy and or radiation therapy up front. Advances in radiation therapy specifically. So one of the things with small cell lung cancer is it does have a predilection or an affinity for traveling into the brain tissue. So there was recently a completed trial looking at giving prophylactic brain radiation while protecting the memory centers of the brain, which has become an area that as a field, we're very interested in, because one of the long-term side effects of brain radiation is that it can affect the short-term memory. Long-term memory remains intact. You know, the who are you, who are we, your life experience, but it's the what did I eat for breakfast this morning, where did I leave my keys 10 minutes ago. That type of short-term memory is primarily guided by the hippocampi, or the hippocampus singular, one on each side of the brain. And that structure can be protected. We've learned that we can improve cognition, or ability for patients to maintain that cognition. And we can either use that technology by itself, or we can combine it with a medication known as Namenda or memantine, which is was a medication that developed for the treatment of Alzheimer's disease. So almost always nowadays, at least in my practice, we talk about incorporating one or both of those aspects of preserving memory function if we're talking about using prophylactic radiation to the brain. And then the other advancements are specifically in screening or detecting earlier versions of this lung cancer, where surgery, if the patient can have surgery, can be incorporated. And if not a surgical candidate, we can actually use SBRT. There's now publications on that. Again, that's for the very early stage versions of small cell. So.
Thank you. Any other questions?
I have a question about SBRT. What does the B stand for?
Body.
Body, okay. I do have a question about this. Oh, sorry.
Can we start with discussion? I have the microphone.
I just had a question about, is there a standard of care if somebody had lung surgery to, remove a lobe, but then the cancer comes back in another part of the lung? Is there standard of care to do surgery again versus radiation?
Well, I think both of us probably need to address that. One of the challenges is determining whether that's the previous cancer that's come back or whether it's a new cancer. So for early stage lung cancer, stage 1, for example, about 20% of those patients will ultimately have something new in their lung. About half of the new findings are a new lung cancer, and about half of them are the old lung cancer coming back. So if it's a new cancer, then often we can re-operate, or if the patient's not willing or medically unfit, or particularly doesn't have sufficient lung reserve, then it would be SBRT as an additional choice. If it's a recurrence and it's isolated, then it's treated as an oligometastasis, so local targeted therapy oftentimes, or possibly systemic treatment. So, and it's not easy to figure out which of those categories it's in. People have, for example, adenocarcinoma tend to have another adenocarcinoma if they have a new cancer. Same thing with squamous cell cancers. So sometimes you can identify them through looking at their DNA, but not always, and it's not commonly accepted way to try to distinguish things. So it's a little bit challenging sometimes.
Yeah, I mean, I couldn't agree more. I think probably the key is defining what the new area is, and so getting some sort of tissue biopsy to help us understand that. If for whatever reason the patient is extremely frail and can't get any interventions, be it biopsy or surgery, in those scenarios we may rely on the diagnostic utility of a PET scan to help us guide SBRT indications. So, but ideally we prove what it is, and if the patient's a surgical candidate for an isolated thing, we'd probably recommend surgery.
Thank you. I do have a question about SBRT because, excuse me, you mentioned if the staging progresses, that's a good use of SBRT, then you can target the new metastases, right? I hope I can formulate this question right, but what if it were the other way, where stage 4 was the initial diagnosis, so there is some metastases already, and then those metastases go away with treatment, so now I don't know if the staging actually changes, but that's the situation. If that's the situation, that's my question. Is SBRT still appropriate for the initial mass as opposed to the Mets?
Okay,
So,
well, let me just.
I don't,
Yeah, no,
did that make
no,
sense?
No, I think I got it. I'm going to try to
Okay.
phrase this. So, patients who start off with a stage 4
Yes.
version, so there's cancer in multiple areas of the body, typically they start on systemic therapy. That's sort of the standard. If on their repeat scans, let's say a few months down the road, there is no evidence of cancer, we don't have anything to target with SBRT. We need to have a tumor that we see that we can treat. So that's sort of best case scenario. You have systemic therapy with a stage 4 diagnosis and we don't see anything on follow-up scans. That's awesome. You don't need me, you don't need him. Now, on the flip side, let's say, I'll try to take this 2 different ways, but let's say everything goes away, but the primary lung tumor remains.
Exactly.
So then that's a question of something known as consolidation, or kind of giving an additional therapy to help seal the impact of the initial therapy and prevent cancer from coming back there. So in those scenarios, depending on the location of the tumor, yeah, we would consider radiation. It may not be SBRT, depending on what it is, where we need to treat or how big the area is, but we would consider radiation potentially in those patients. And then I guess the other avenue, which is, let's say most things respond, but a couple areas persist, and that's the area that we've had a lot of really good data recently, overall survival potential benefits as well, with kind of picking off those areas that have moved with SBRT. And in those studies, it allowed up to, one of the studies was up to 3 areas, and then another one of the studies was up to 5 areas. And I think that's sort of how we define oligometastases, something less than 5 areas of
Less than 5?
yeah, less than or equal to 5, I guess, on most trials.
Thank you very much.
How do you distinguish between a recurrence and independent cancer?
Well, if you have a single new spot show up in a lung, that's the most challenging situation. And it depends on where it shows up. So, for example, if it's in, we call things regional recurrences versus distant recurrences. It's pretty easy if it shows up in a bone as opposed to in the lung. The real question is, if they have a single isolated spot where something shows up, is that a new cancer or a recurrence of the previous cancer? So that's the situation I was talking about before. It's quite difficult if it morphologically resembles a lung cancer to determine if it's something new or related to the previous one. Fortunately for us, not necessarily the patients, recurrences tend to not be isolated. So it may be in a lymph node and someplace else. So if you have a pattern like that, it's more likely that it's going to be a recurrence than a new cancer that presents with regional spread.
So if you, within a lung, if you had bronchoalveolar in one spot and it comes in another spot, you'd be able to identify that as part of a recurrence.
Well, that is a more specific and problematic area. So the old way of referring to it as bronchoalveolar, but it's a type of an adenocarcinoma, and those tend to be multifocal, as opposed to metastasize or recur someplace else. And we're understanding this more as multifocal disease, and we tend to treat it as mostly new primaries. So local control is typically what we try to aim for with surgery or radiation if they become sufficiently large or start to get dense. A lot of times these little hazy areas we call ground glass opacities, don't represent an immediate invasive cancer threat. There are things that we can monitor over a period of time, and there are certain CT characteristics that suggest that now this is starting to change into a minimally invasive or an invasive cancer, and that's when we start to get involved in those. So we're becoming sort of more conservative about the management of these ground glass opacities that might develop into something that we previously called a bronchovelar cancer. I was in China last week, and they were operating on a tiny little ground glass opacity this big, going to take somebody's lobe out. And we would never operate on something like that. It doesn't have sufficiently worrisome characteristics to warrant a big operation.
Okay. I just wanted to know how important is genetic testing in helping you?
You know, we talk about looking at the genetics of the tumor. In lung cancer, that's very important. When we talk about kind of familial issues, so is my family at risk for this? It's pretty uncommon to find genetic syndromes specifically just related to lung cancer, but obviously we tend to take a thorough family history to see if there might be patterns that would suggest that there are an appropriate consultation with a genetic counselor might be appropriate to help with any family issues too. So when we talk about looking at the genetics of the tumor, typically that has more to do with the patient in front of us and how we're going to treat them. I don't know of any lung genetic issues.
No, but I would say that it relates to how we try to characterize the tumors. And so not just genetics, but other targets for treatment are important to assess. So now, a few years ago, we would only rarely send things off for analysis of appropriate targets. We only had a couple of targets we could look at. And about 2 years ago, we had 4 or 5 targets that we would look at. Now, in our internal assessment of the characteristics of the tumor, not just the genetics, but other molecular targets and immunotherapy targets, we look at 1,380 different characteristics. And that's likely in the next version to increase substantially above that. So it's becoming very complex, but it also illustrates the opportunity that's available to treat these patients.
Thank you so much. I want to really thank all of you for being here today. I really appreciate the information. But I do have one final question, and that's regarding palliative care. One of you mentioned, had a slide that a palliative care team member is part of your team. And I wonder if any of you would comment on the role of palliative care during active treatment.
You know, we know that palliative care can really add a layer of support for patients that can be very helpful. Studies have suggested that the early incorporation of palliative care in the treatment of lung cancer patients actually improves the quality of a patient's life, which we expect it to, but actually can improve survival in a meaningful way. So somebody else addressing some of the issues that during your 20-minute appointment with the doctor can't all be assessed. You know, we tend to use, in most of our offices, we have nurse practitioners, physician's assistants, nurse navigators are something that we're all using now, which is we're trying to reach out and really give that extra layer of support that perhaps wasn't there. I think formal palliative care programs really do help that process and really integrate well with your treatment team too. So palliative care in no way means that we have nothing left for you, but it does mean that we have things to help with symptoms that might be related to either to the tumor or the treatments that we do. You know, the whole role of palliative care in hospice is evolving. So hopefully we'll continue to have changes because we talk about patients who have symptoms related to what we're doing to them, but living years at a time. So does that mean we only have to use certain palliative care services at certain points in their journey? No, and hopefully that'll continue to change as time goes on too.
I had a question. I understand there's a trial going on for using immunotherapy for early stage lung cancer, but to prevent recurrence. And I was just curious if there's any kind of early results from that and how that's going.
Not yet. These are really the trials that are being looked at least trials that, let's say, we have available that are more national, are looking at what's called neoadjuvant treatment. So before somebody goes to surgery, let's say they have a resectable tumor, there's nothing to suggest that they can't have a good resection and they could go to surgery right away and their chance of cure is improved significantly. But looking at the neoadjuvant aspect of immunotherapy, so trying to give, typically it's a combination of 2 immunotherapies prior to it, and then what happens is then the patients are followed long term compared to a group that doesn't get that immunotherapy. The interesting thing about neoadjuvant therapies is that you actually can, when the tumor gets resected by the surgeon, you can look and see what it looks like and see what kind of immune effects have happened there too. Hopefully that priming, much like we talked about what's the timing of immunotherapy, can that prime the immune system long term to help prevent further recurrences or even new tumors in that respect. So it's early. If that trial is available, obviously I would encourage, talking to your oncologist about those issues. A lot of times, the nice thing about multidisciplinary conferences is that this can all be presented before somebody just says, I'm just going to take them to surgery, go see the oncologist afterwards, or, to at least explore the other options that may be out there too.
And there are 2 that I know of trials looking at SBRT for early stage non-small cell lung cancer followed by immunotherapy. One is looking at pembrolizumab, which is a kind of a Keytruda, and the other one is looking at atezolizumab. So there's 2 different ones. Our institution is participating in one of them, but we're just getting it off the ground. So this speaks a little bit to the timing. So for the surgical studies that are ongoing, it's sort of the immunotherapy first. For the radiation studies, you want to get the radiation first and then go on to the immunotherapy, and it has to do with the optimal priming of the immune system. So, but it's really, we're in the infancy of this. So, but it's exciting. We should have hopefully some early results in about a year.
All right. Well, thank you for your wonderful questions, and thank you, doctors, for your time and expertise this morning and all the great information. Okay, so that brings us to our break. We're a little bit ahead. And it's still snowing, so that's fun. We are going to come back here at 11:05 and start promptly then. So restrooms are just out the hallway. There's still some breakfast, coffee, water, but we'll see you here at 11:05. Thank you.